Thank you, Arosha. May I also mention that this team's got together after 17 years, and it's an absolute pleasure to deliver this lecture chaired by my house officer at Colombo South Teaching Hospital, and have as my co-speaker the demonstrator, post-intern demonstrator in the department those many years ago. It's indeed a privilege. It's customary to deliver a few conflicts of interest statements in lectures, so I've just put a few of mine, but the conflicts actually are relevant to clinical governance, because in the last 15 years, I've batted around a bit, dabbled in medical management, and in fact in clinical governance. So shortly after arriving in the UK, management sometimes is, some people acquire it, some people have it thrust upon it, and some people are born to it. Let me assure you that it was thrust upon me, because no sensible person becomes associate clinical director 2 years after coming to a new country. And nobody in their right mind takes on the post of assistant medical director to introduce clinical governance to a trust that is failing 3 years after coming to the UK. So I am truly certifiable. So take that in mind when you listen to the rest of my presentation. Since then, I've been involved in management at a different level, but let me assure you that I am a clinician. I still do 4 clinics a week. I still do ward rounds on a ward, and I'm still on call. So I'm not one of these managers. So what is clinical governance? What does it mean? Why do we do it? How do we strive for excellence in professional activity? What feedback mechanisms do divisions and departments where I work have? And how do we manage risk? These are what I would try to cover in my presentation. So I will talk about the parable of the elephant and the blind men, but I realized that elephant conservation and endangered elephant species are endemic in Sri Lanka in more ways than one. So I assure you there's nothing political about this slide. It was done well before last Friday. It's one of the stories from the Buddha's parables, and clinical governance means different things to different people. So what is clinical governance? Essentially, it's a system. It's a system which enables organizations and institutions to do the right thing. It's about creating an environment for people like you and I to deliver excellent services. Now, I'm sure you'll be aware that many of us deliver very good services, but the systems are not up to scratch. This is about developing systems to make them as good as the people who work in them. By the way, this is my plug for the new inductees in clinical fellows, just to get them onto the same wavelength. So, if I were to summarize what is clinical governance, it's doing the right thing at the right time, in the right way, in the right place for the right patient. Martin's lecture just established one place where clinical governance is so vital in ensuring the quality of that service. And I understand it's heavily audited and policed. So Arosha referred to the pillars. And these are actually the pillars of clinical governance. And on these, the conceptual house of care is built by putting the roof of governance. So none of this is management rubbish, as many people say. None of this is politics. It's the core of what we do as clinicians. Patient safety can be compromised by a wrong diagnosis, wrong treatment, delays in treatment, errors in treatment or techniques, and of course, faulty equipment. Medication errors, and of course, not involving the patient. So how do we prevent these? How do we mitigate against risk? So we have to deliver safe care by creating an environment, an ambience, where safety issues can be raised, a no-blame culture, to ask what went wrong, not who did what wrong. That's governance. This is achieved by sharing learning from serious incidents, reporting incidents using Datix, which is the tool that we use in our trust, and reflecting on previous incidents as a team, as a multidisciplinary team, not just ourselves. Some of the things that we look at on the ward are pressure ulcers, because we've got fairly dependent elderly patients on some of our wards. We don't like people having falls and breaking bones. As a person who runs an osteoporosis clinic, I'd rather prevent them than involve my orthopedic consultants. And of course, we really don't want to have medication errors, particularly in insulin, which is in my primary subspecialty. And of course, as a trust, we are judged by how safe our environment is by the rates of healthcare-associated infections. So it's not just a government target. This is about patient welfare and safety. And AKI, acute kidney injury, and sepsis are some of the priorities at the moment because they are some of the commonest causes of increased mortality. I won't touch on mortality reviews because my co-speaker is going to touch this very extensively, so I won't mention any more. So how do we manage risk? First, obviously, we've got to look at risk and grade it. So let's do a simple exercise in assessing risk. So this chap's standing barefoot on a metal ladder in a pool of water, handling electric equipment, presumably installing electrical fittings. So pretty risky, but if you stand barefoot, that's really risky, isn't it? So assessing that risk, stopping this from happening through silly rules like saying, wear rubber shoes, don't stand in a pool of water, insulate well. So clinical governance is also silly stuff like that. And many consultants in the UK think it's silly stuff. So what is this built on? Well, it's about how an incident develops. So there are organizational factors, workplace factors, personal factors, defenses, which we put in through our risk management. Unfortunately, sometimes incidents do happen with the best efforts. Why does this happen? Well, it happens because there are holes in those defenses, and this is explained by this thing called the Swiss cheese model. Now, it's not just Swiss cheese. Remember that the cheese is melting all the time in the heat of an overworked NHS. So new holes appear in places you didn't expect. So the risks of something happening, of something going through these new holes and existing holes in the system are very high, and that is risk management. It's a dynamic process. So clinical governance is not a static tool, it's a dynamic process. And it's about risk management. So why do we manage risk? Well, obviously, to make it safer. If I'm the chair of the board of management, I'd say, in addition to that, it's the risk to reputation. We get statutory requirements to do this. We might get fined. Whatever it is, it's still about harm. So how can we manage it? Well, it's a three-stage process. Identify it, document it, assess the chances of it happening again, and put that learning into practice. So this is the fundamental rule of clinical governance. But it gets a bit complicated. So how do we ensure best care and treatment? So some of the things we look at are ensure that the staff are up to date. So we do that through appraisal, see whether we've got our CPD points, and I just got some really good ones on stroke from Martin. So I'll definitely reflect on that in my mobile Royal College app and get my points. And then I put that up when I go for my appraisal. Obviously, the rest of it is self-explanatory. Good record keeping in particular is important because we do a good record keeping audit as a mandatory process in all our wards for all our juniors. They've got to do 5 sets of medical records and reflect on it. So how do we know treatment's effective? Well, there are clinical audits, which are some are national, some are local, and they can be due to general internal medicine, acute internal medicine, or subspecialty. And if you're a trainee in the UK, you've got to do one GIM audit and one subspecialty audit, because dual accreditation is there to stay, and we'll talk about that later. So there are local audits. So audits are not just something you do because you feel it's got to be done. It's a focused look at what's happening in your service. There has to be an annual audit plan. And these are some of the things that we do. And the prescribing audit is another important one. Antibiotics, more so. What are we trying to avoid? We're trying to avoid never events. Never events are things, as you might imagine, things which should never happen. And these are some of the criteria on which we judge a never event and things we should do. So what are these? Well, there's surgical ones, there's the medical ones, and there are ones in general. So these things should never happen. Zero tolerance. We need to be a responsive service in terms of patient experiences, and these are audited. So forget about the car parking complaints. There are enough complaints or concerns about communication. They didn't know about something. They consented to something that they weren't aware of. All those are important. Complaints are something that we learn a lot from. And in my alternative job, since my partial retirement, I work one day of the week for the Parliamentary Health Service Ombudsman, where we review complaints which patients feel are unresolved by the trust. And there's a lot that can be learned from those. When somebody expresses a concern, it's not a personal criticism. It's a concern. And that's an attitude that is part of clinical governance. Compliments are good. We record them, we reflect on them, we feel good about them. It's not all negative. There's a friends and family survey where you ask people, would you really want your friends and families treated in this hospital? If the answer is yes, I think we're doing a good job. And that's done as a national survey. Is that all? Well, health and safety, which is also thought of as a waste of time, has a lot to do with making the hospital a safe place. And each of these is an induction lecture in itself for staff. I've just compressed some of the slides into this. So all these, and if you're a medical manager in Sri Lanka, you'll appreciate these are what the College of Medical Administrators sorts out. And of course, the annual fire lecture, if you don't go for that, you get docked a year's pay because you don't get your pay progression. Well, it's one of the essentials. If you're a manager or a leader, clinical director, medical director, you are judged on how well you lead. And there are measures of this, which are done externally. The junior doctors feedback on the Junior Doctors Forum. That helps with this. So this is the worst form of leadership. And in my time, I have worked in circumstances like this. But happy to say I'm not there now. And I'm sure all of you have felt that way at some point or the other. So how do we look at these? Well, we look at clinical performance indicators. We design these. We agree on them. And we use them to compare ourselves against centers of excellence or our peers. It's a measure of our own performance by methods we agree on. It's not imposed on us. As a profession, we have the right to do that. And these care quality indicators are fairly straightforward. Now, because this is General Internal Medicine Forum, I've decided to pick some from our acute medicine list of indicators. And these are the ones that they look at. They're not unreasonable, as you will agree. And sometimes, in my other hat, as a member of the governing body of a clinical commissioning board, we use commissioning for quality and innovation tools to incentivize some of these. So basically, we say, if you do well and excel in this, we'll pay you a bit more this year. give you a bonus, in other words. So this year's ones: acute kidney injury, sepsis, dementia and delirium, antimicrobial resistance, health and well-being. So it's a balanced scorecard. So if you do well on these, that means your local hospital does well. There's a conflict of interest, so I don't do it for Mansfield, I do it elsewhere, 100 miles away. So what are we trying to do? We're trying to improve patient care, use a patient-centered approach, reduce risk, learn from mistakes, and be accountable externally. None of these are bad things. They are not a threat to our independence. I think the most important thing here is it's clinically led. We need clinical engagement. So what is it about? Well, if it's these, every member of staff must recognize their role. So how do we do it in the trust? So in the next 3 minutes, I'll just show some slides about how we do it. Well, these are some of the things we do. They say that managing doctors is like herding cats. Some people try to do it this way, but that's not really successful. People who've tried it have failed miserably. So who is really responsible for all this? Well, nominally, it's the chief executive, the medical director, and the risk management team. So do you think you're responsible? Well, actually, you are. We all have responsibility. What can we do individually? Nothing new there. So each of these might have a bit of mandatory training attached to it. And I don't think any of these would be unreasonable. And there are methods of assessing whether we are doing that correctly and benchmarking us. That's clinical governance. The ability to report safety incident is one, and this is a very important part of it. The ability to report, to discuss it in a non-threatening environment. So remember, if you spot it, you sort it. If you can't sort it, you report it. So I've tried to summarize clinical governance, but it's basically a journey, not a destination. And if any of you fell asleep, that would be postprandial sleep disorder, physiological. If I fell asleep, that's narcolepsy. And so here are some references. I'll leave the slides. I'm very happy for them to be distributed. They are not copyright. They're all my slides. And in terms of how we get clinical governance to work, it's got to be a hands-off growth. Each of these buds will grow on its own if the right soil and the right management climate is there. And that's where leadership comes in. And certainly I've been privileged to work with a medical director who's actually set the stage for this and has brought the trust up very well, nicely. And one of the shoots you notice is mortality, morbidity, which my colleague will be doing. Thank you very much.
Thank you, Professor Fernando.